to be a focus on podiatric issues and wound care, critical insufficiency, and how we balance that side of the equation. And I'd ask Angel Freeman, is she here? Perfect. Why don't you come on up this way, and we'll get started. And I think we are, if I believe, we are on time, and actually in front of time. So I'm gonna give you 10 extra minutes to play.
Sorry. Good afternoon. My name is Angel Freeman. I'm a podiatrist with Upperline. Oh, thank you very much. Just green is click forward, I'm assuming, right? Yep. Okay. Technologically unadvanced. All right, so we'll talk about diabetic foot ulcers, and some of this stuff I'll fly through. I put my cell phone number at the end, so if you want a copy of this presentation, or if you just want to send me some gross pictures and ask advice, then that's totally fine. Just take my cell phone number down and text me anytime. So diabetic foot wounds. Oh, hold on. Oh. Already. Oh, hold on 1 second. There we go. Okay, sorry. Figured it out. All right. Diabetic foot ulcers, chronic wounds caused by a combination of neuropathy, poor circulation, and immune dysfunction in diabetic patients. So we've been talking about the significance of these things all day long. 34% of people with diabetes develop a foot ulcer. 50% of ulcers become infected. 20% of these lead to lower extremity amputations. And then, of course, we always talk about mortality rates when it comes to significant lower extremity amputations. You know, unfortunately, sometimes podiatrists get a bad rap because it's like, oh, you take a tip of a toe, then you take the whole toe, then the TMA, then the BK, then the AK. So, you know, we try to get away from that, and we're hopeful that when we see patients and they have an amputation, it's a little bit more of a wake-up call. Unfortunately, that's not always the case, and then they sort of keep going back. A little bit about the etiology and pathophysiology of diabetic foot ulcers. So we have abnormal pressures on the feet. This causes chronic inflammation. Of course, these patients are neuropathic, and so they don't always feel that these things are going on. They build up callus tissue, and then calluses break down and form ulcerations. Biomechanical abnormalities cause high-risk areas of ulceration. So this is just a little diagram showing the higher risk areas of ulceration. Anywhere that's prominent on the foot, that's going to be a high-risk area of ulceration. So we tend to see the ball of the foot, the pads of the toes, especially when patients get hammer toes. And here's just some clinical pictures of this. So fifth metatarsal head on the left. In the center, I kind of tell patients when they come in, when they stand up, their foot is a little bit like a tripod. So highest areas of pressure are first metatarsal head, fifth metatarsal head in the heel. The heel has a nice fat pad, so we don't see a lot of neuropathic ulcerations necessarily on the heel. That's more pressure ulcer area. But first and fifth metatarsal heads, certainly, we see a lot of pressure ulcers, neuropathic ulcers. And then, of course, we've all seen these diabetic feet with these really rigid hammer toes. They get ulcers on the tips of the toes or even between the toes. I kind of tell my patients, too, there's not a lot of meat to a toe. So, unfortunately, once that skin starts breaking down, it can get bad pretty quickly because there's just not a lot of stuff between the outside world and the bone. So that's why, you know, these become such high risk. So what makes a wound chronic? In diabetes, wounds often become chronic because they get stuck in the inflammation phase of healing. So we talk about, let me go back a little bit. We talk about the phases of wound healing, and we've been talking about inflammation all day long. They get stuck in the inflammatory phase of healing, and they just can't move past it. And that high blood sugar, that chronic high blood sugar, causes them to remain inflamed, and they can't move on. So next, we're going to talk a little bit about how to assess a diabetic foot ulcer. So when we're looking at a diabetic foot ulcer, first thing we look at is it partial or full thickness. The one on the left is a partial thickness ulcer. Even a callus, a lot of podiatrists will consider a callus a partial thickness ulcer because at that point, especially if they're an uncontrolled diabetic and they have any history of vascular disease, they're on their way to getting an ulceration. So partial thickness and full thickness. We also like to describe the wound base. So all the way on the left, this is what we like to see, a nice, healthy, granular wound base. It's kind of gross, but we a lot of times will say, oh, it looks like ground meat. That's kind of what we're looking for. In the center, you've got a fibrotic wound base, and then to the right, you've got an ischemic or a necrotic wound base. And you can tell a lot about the wounds and the etiology of these wounds by the wound bases. So if you see, obviously, a necrotic or an ischemic wound base, then you're more likely thinking that this person probably has some component of vascular disease. We like to look at the exudate. Are they heavily draining wounds? Are they mildly draining wounds? What kind of exudate is it? Bloody, serous sanguinous, serous, or purulent? Obviously, purulent, we're worried about infection. And then we like to describe the peri-wound skin, so all the way on the left, that's something that we call maceration, which is where it's kind of got that whitish wet look to it. That's a heavily draining wound. In these types of wounds, you're going to increase frequency of dressing changes. You may use more absorbative dressings and things like that. In the center wound, this is something called epibole, which I always joke, nobody says that word right, or nobody thinks that they're saying that word right. And then on the end, you have a hyperkeratotic peri-wound, and that has to be addressed also. It needs to be pared down. Diagnostic imaging. I am always telling my staff every single wound needs an x-ray. Every single wound needs an x-ray. It doesn't matter how little the wound is, every single wound needs an x-ray. X-rays are needed to help detect underlying bone and joint issues that can complicate healing. So it gives us information about foot structure, bone erosion, possible osteomyelitis, gas in the soft tissue, and also just to have a baseline. It's very similar to the way that vascular surgeons will use ultrasound. Every patient needs an ultrasound. Every patient needs an ABI. In podiatry, every wound needs an x-ray. Hopefully this is going to work. Okay, so here is a picture of a foot wound in the office. Now, you can kind of tell from this picture that this person has had a previous second toe amputation, but otherwise this guy was new. He was new to the area. He just moved to Tennessee, so I don't know anything about his history. He's got a really long podiatric history, and a lot of these patients, they're not really great historians either, so they can't give you a lot of information. So we can learn a lot from just taking an x-ray. So that's his x-ray. I mean, you can kind of see that he's had obviously some previous work before. He's got some retained hardware in there. He's had a previous second toe amputation. You look at his lateral view, his foot is basically just one giant bone. You would never know that by just looking at his foot without an x-ray, and that just tells us a lot more about what's going on. He's obviously had a lot of previous surgery done, and there's vascular clips and everything else. His foot is just one giant bone, so we know that it's basically rigid and solid as a rock, so that also comes into play in terms of like offloading and what we're able to do and what we're not able to do. Here's another example of why you need an x-ray. This is an x-ray of a patient with a 5th metatarsal head ulcer on January 12th. She went into the ER, never really followed up, and then went back to the ER. That was in May. So you can see that already, it was lucky that we had these baseline x-rays because we can compare, but that also gives us an indication of progression of the wound and osteomyelitis and all that other stuff. That's another image. This is all of the same foot. So you can see that bone has started to be eaten away. You can see the shadowing of the ulcer there. Here's another perfect example. This is a patient that I got consulted on in the ER. It doesn't even really look like he has a wound. The toe looks, of course he comes in, he doesn't have a PCP, doesn't have any, has never established with a podiatrist. Okay, the tip of the toe looks not so great, right? Bottom of the toe, that looks a little more scary. Not really sure what's going on. Maybe it's ischemic, it looks dark. Take an x-ray, it's full of gas. So this is a surgical emergency, straight to the ER, amputation of the toe, IV antibiotics, all that good stuff. So x-rays are very important. Next thing, vascular referral. Every single patient that has a wound, almost every single patient, needs a vascular referral. If it's a traumatic wound or something like that, or they very obviously have decent blood flow, they're younger and they're non-smoker, whatever, but in general, if a patient has a chronic wound, they should have a vascular referral, point blank. Other things, nutritional status, dietitian referral. Most of my patients will pretty much refuse to go see a dietitian, but you can talk to them about it. Labs. A1C is very important, obviously, and even things like albumin, which gives us an idea of their protein intake and their overall health and their ability to heal a wound. Smoking status, we've been talking about smoking all day. Wound culture, when you're assessing wounds, you're going to hear, I'm kind of on the fence about these. I generally don't take in my opinion, you shouldn't take a wound culture unless you see clinical signs of infection. Not everybody agrees with that. Sometimes it's nice to have a baseline wound culture so you know what kind of bacteria are sort of colonizing the wound bed. So if they do happen to get an infection, you have a good idea of what type of empiric antibiotic that you want to start them on. But in general, I won't culture wounds unless I'm seeing clinical signs of infection. Because of course we want to practice antibiotic stewardship. We don't want to treat patients with antibiotics unnecessarily and create resistance. And then lastly, classification systems, Wagner, and then the University of Texas classification system, which are the most commonly used. Now treatment. So debridement is the main safe treatment for diabetic ulcerations. When you look at this wound on the left and the wound on the right, they're the exact same wound on the exact same day. So the left-hand side was when they came into the office, and then next is post-debridement. Same thing over here, same wound, same day. Cleaning, hygiene is like it's one of the most important parts of wound care, and a lot of my patients unfortunately don't have great hygiene. So when they come into the office, they kind of get the full scrub down. So left, again, same day, wound before, wound after. And then in wound care, it's pretty easy. We have a joke in podiatry: if it's wet, dry it. If it's dry, wet it. That's really basically all you need to know. If you've got a lot of drainage, then you want to make sure that you increase frequency of dressing changes, use more absorptive dressings, and there's a bunch of different types of dressings, and you can use some of these more advanced wound care techniques as well. And then, of course, offloading. Offloading is one of the easiest things that we can do as podiatrists to help decrease pressure on a wound. Expect patients to be non-compliant. I always talk about this. You have to meet your patients halfway, and just telling them to stay off of their feet is just not going to work. And to me, that's just a lazy way to practice. Like, you know, I'm going to force them to be, I'm going to force them to get better against their will is kind of my motto. So what do? You use felt, you use anything adhesives. I tell the patients I can't change the way that your foot is, I can't change the shape of your foot, but I can change the floor. So what do? I cut some felt, I stick it to their feet, I put that underneath and incorporate that to the dressings, and I tell the wound care and the home care nurses that when they're going to visit these patients at homes, when you change the bandage, leave the felt in place. We want to keep the offloading in place so that way when they walk, these wounds are not touching the floor. Here's another example of offloading. This is a diabetic insole. You can cut out areas of high pressure so that way when they're walking in their regular shoes, they're decreasing the pressure on the metatarsal head. Same thing. This is a patient that came in with a 5th metatarsal head ulcer, and I cut out a hole in the surgical shoe. If the patients will agree to wear a surgical shoe, this is a really great way. The surgical shoes, that insole comes out, so you can cut a big hole in there. You can kind of see that from the side. That's down low. And then here's a little progression of her wound. First visit, next. So and that's just basically offloading. So it's not always a ton of stuff that you need to do. Okay, so this is a case study. So it was an initial case, patient, neuropathic, uncontrolled diabetic, had never established with a podiatrist before because he never had a problem before until he stepped on a toothpick, and he's neuropathic and his A1C is 8, so he couldn't heal. So this was after the first debridement in the operating room, took him to an IND. You can see the wound base is all gross, and everything is all gross. Offloading, this is a guy, these people, they don't want to stay off their feet, so you need to learn to work with them. I wish that all patients would just listen to us and stay off their feet, but they're not going to do that. So I offloaded his foot. We, of course, keep up with local wound care. Gets better, smaller, and then he's healed. And then lastly, some advanced wound care technology. So skin substitutes and wound vacs. Hyperbaric oxygen, I would love it if my patients would agree to do hyperbaric oxygen. It's just really time consuming because they have to do it every day and they have to drive there and they don't want to do that. Skin substitutes and wound vacs. So here's a case of a patient that we used a wound vac for. So this was a patient that had an open partial 5th ray amputation for treatment of osteomyelitis. These people, they just don't hear regularly when they're very uncontrolled diabetics. You can even see the suture lines because originally I had partially closed it. But then it was draining a lot, and I was concerned that it was like leaving infection there, so I cut those sutures out, and you can see even the sutures will create a wound. So you have to be really careful about taking these patients to surgery because you can do more harm than good. But we used a wound vac. You can see there, really nice, all the bone is covered, didn't have to take any more bone, slowly but surely got back to normal. So wound vacs are great. And then this is a really cool case that I'll leave you with using skin substitutes. So this is a 7-year-old male, he had cellulitis, went on to gas-forming infection and an anterior wound, basically. So that was him after the first debridement. So you can see his tibialis anterior tendon is completely exposed. And he had multiple washouts, vascular intervention, 6 weeks of IV antibiotics, and then a combination therapy using skin substitutes and wound vac, in addition to also Una boots. And this took 4 months of duration for this to get there, but I'll show you some cool pictures. So this was while he was still in the hospital. This is multiple washouts going to the OR. This is a really cool product by Smith & Nephew. It's a collagen-based product, and you can sprinkle it in the wound. It can help build it back up, and basically what we want to do is fill in all that deficit first. Then we were able to get a lot of that deficit to fill in, and he's got a lot of really great granular tissue, but that tendon is a problem because it's really hard to heal overexposed tendons. So then we had to think of another thing that we could do. So this is a skin substitute. It's called Stravix. It's a product by Smith & Nephew, which I have no disclosures. I don't speak for them or anything. It's just a great product. But we use that on there underneath a wound vac, and that was to help get that tendon covered to just build some tissue back. That was him after that, after we used the wound vac. After this point, we started going to Una boots to help control edema, because he didn't really need any granulation tissue formation anymore with the wound vac, but we wanted to control the swelling and the drainage. So we went on to do some Una boots, change those every week, slowly healed out, and he can still move his foot. This was him last week, so he's got a tiny, tiny little wound left there on the anterior aspect of the ankle. But healing these wounds are possible. Collaboration between specialties, podiatrists, endocrine, vascular, infectious disease. and making sure my nurse practitioner, I kind of joke that we're building our Avengers group. We all kind of get in there and we're like a little girl gang. But you need to talk to these people. You need to be able to call people up on their cell phone and talk to them for real. Vascular surgeons, endocrine, and you need to convince your patients that they need to see these doctors, because they're going to come in and they're going to complain that they have too many doctors already, and so they don't want to take the referrals that you give them, but you have to figure out a way to get through to them that they do need all of those doctors. And again, that you need to understand your patients and tailor your treatment plans to meet their needs. They are not going to want to listen to you. That's how they got in this area in the first place, but we will make them better against their will. That's my cell phone number. You can take a picture of it if you need anything, or if you want a copy of this presentation, if you ever want to send me any pictures for advice or anything like that, I'm happy to chat with you. And that's basically all.
Hey there, I'm Ashleigh. I'm a nurse practitioner at Vascular Institute. I'm going to be talking about critical limb ischemia and advances in wound care. Oh, sorry. Oh, okay, I'm sorry. Okay, so we've talked about all of the different stages of peripheral artery disease already, but just a little bit of an overview. What I'm going to be talking about today, critical limb ischemia, or CLI, is a severe obstruction of the arteries which reduces the blood flow to the extremities. It's like the end stage of PAD in our patients. It is characterized by rest pain, non-healing wounds, and then potential or actual gangrene. A lot of times it does require urgent treatment, or these patients are going to lose their limbs, which, as we've talked about, really increases the risk of death. So the pathophysiology of CLI can be, most of the time it's caused by atherosclerosis, and that's the primary causes of chronic limb ischemia. There's also thrombosis and embolism. I should have said that is what causes more acute causes of limb ischemia, not necessarily acute causes of CLI, but risk factors that a lot of people have spoke on: smoking, diabetes, hypertension, and hyperlipidemia. And the reason this is a problem, there's reduced oxygen and blood supply to the tissues, and that's why there's increased risk of ulceration and necrosis. So I just added some pictures of patients that had that I've seen in the past over the last 5 years I've worked at Vic, and just to show that there's different. You can it presents differently. These are all feet or ankles. But you see the biggest picture here, it's multiple areas of gangrene on this lady's toes. And then obviously there's a pressure area on that ankle and the heel. You can't really see the heel very well, but that is started as pressure, but obviously we're thinking that there's something going on with the blood flow causing that necrosis at the ankle and at the heel. And the bottom picture, that is actually it's a wound that's been present for years. I saw him as a new patient not too long ago, and he has osteo that's being treated with HBO at a wound center locally, and was sent to us for a vascular evaluation, and he's got iliac artery occlusions. So we talked about this too already. Signs and symptoms: rest pain, especially at night. It's really with leg elevation, I don't just say like at nighttime. I say whenever you get in the bed and you lift your legs up, or you get in the chair and you lift your legs up, are you having a lot of pain or numbness or discomfort? Is that happening for my patients? Ulcerations that are slow to heal or don't heal. Coldness, pallor, diminished pulses in the affected limb, and again, gangrene. Again, some other presentations, this is an ulcer that it's over a bony prominence, so we see that in arterial wounds a lot of times. And then, of course, that the fourth toe here, that's gangrenous. That is either already amputated or should be shortly of a patient of mine. Diagnosis, ABI, Doppler ultrasound. At our facility, we do Doppler ultrasound with ABIs, and then also other imaging like plantar acceleration times to tell how well a foot is perfused before and after procedures. CTA, of course, and then angiography, diagnostic. Hopefully we, whenever we get to that point that a patient is needing angiography, then we have angiography with intervention so that we can just do what's best for the patient. So there's conservative measures for treatment of critical limb ischemia. Of course, we want to tell our patients to quit smoking or cut back on smoking or quit smoking if they will. Glycemic control for patients who have diabetes, exercise. I'm always telling my patients, if they're diabetic and they have a diabetic foot ulcer, then I'm like, we need to work with podiatry because exercise is really important. Walking is important for our patients who have peripheral artery disease, but it's we have to weigh the risks and benefits of that because they need to offload, like Dr. Freeman mentioned. And then, of course, pharmacological interventions, antiplatelets, and statins we've talked about a lot today. Those are very important for our patients to take and to be compliant with if they're willing. Surgical and endovascular interventions. There's angioplasty, atherectomy, stenting. We've had great presentations by our doctors, our surgeons, talking about the different options for therapies that endovascular therapies that we can offer our patients to help them. There's also bypass surgery, of course, if they fail endovascular therapies. And then, of course, amputation. Unfortunately, sometimes amputation is required whenever a limb's not salvageable or they failed multiple interventions. So I was asked to talk about advances in wound care. I worked in wound care whenever I was an RN at a local wound center, and so I have some experience in hyperbarics, and so I'm trying to draw on some of that, and then also some what I've looked up to try to see if there's been any updates. So, like Dr. Freeman mentioned, it's a multidisciplinary approach between our office and other vascular providers, wound care teams, podiatrists. There's different therapies. There's collagen-based dressings, negative pressure, growth factors. I know that those were used whenever I was in wound care. And then skin substitutes, that was mentioned. It's really amazing how well patients do despite having a lot of risk factors whenever some of these advanced techniques are used. What these can do is cause or help encourage faster healing, which if the wound's healing faster, then it reduces the risk of infection and amputation. So HBO therapy or hyperbaric oxygen, what this does is it increases the atmospheric pressure while providing 100% oxygen atmosphere. This picture is a monoplace chamber. That's all of the local wound centers, I believe, around here are all monoplace, where one individual person goes in there. There are also multiplace chambers in the country and the world that I don't know a whole lot about, but I know that they're in the chamber that's pressurized, and they individually have like masks that go over their heads to get that 100% oxygen. What it does is it helps promote development of new blood vessels. But again, like Dr. Freeman mentioned, it's a full-time job. That's what we used to say whenever I worked at the wound center. We used to say 5 times a week. We want them to come every day, be compliant. But it's you have to drive there, like was mentioned, and then it can be 2 to 2.5 hours for each session. So this is what I was trying to figure out, if there was any changes in this. Because this is a vascular conference, I kind of highlighted the acute peripheral artery insufficiency, and then the skin grafts and flaps, the compromised. So I think the big takeaway for these diagnoses for HBO is that there's a clock on these. So if you have a patient that has acute peripheral artery insufficiency, a lot of times they need HBO. It's going to be beneficial for them. They're going to need it in really quickly, days. And then skin grafts and flaps. I know the last time I heard, I think it was like 2 weeks that they need it. They need it really quickly. So being on top of it and trying to get them into the therapies that they need is important. So this is just increases oxygen delivery to ischemic tissues, promotes angiogenesis and wound healing, and it helps inhibit bacterial growth. It's really beneficial for non-healing ulcers, especially if a patient has diabetic foot ulcers. It can be approved a little bit better for, they have to have certain, they have to meet certain criteria. Studies show improved in wound healing rates and limb salvage. There's challenges to it. It's limited availability and insurance coverage. That was always a problem whenever we were trying to get patients approved. Not everybody can get into an HBO tank. They have to have qualifying diagnosis. But wound centers are great resources to reach out to them to get that information if you have questions about it. And it can be complementary to our vascular care, endovascular, and surgical. So just as a conclusion, it's serious, it's life-threatening. If something's not done about it, they could lose their limb, they could lose their life. HBO therapy has promising it's providing promising outcomes to these patients. Multidisciplinary approach is essential between vascular, podiatry, wound care, primary care, but early diagnosis and interventions are crucial to improving quality of life and to save these people's limbs. Thank you.
Good afternoon, evening. My name is Jason LaPorte. I am a hospital-based podiatrist for Upper Line Health, the Village Podiatry Group locally, and I was asked to speak about venous ulcers. Venous ulcers they're the most common form of leg ulcers. They affect 1% to 2% of the general population. That's up to 4% of age 65 plus, so it is a more common problem as we age. Account for approximately $15 billion in U.S. healthcare costs annually and cause significant morbidity and quality life impairment to patients that they're affected by. They are the result of chronic untreated venous disease. So a lot of this is pretty simple. I could sum up my whole presentation as patients should wear compression, but I was asked to fill 10 minutes, so we're going to go through some of the core concepts of why you should be encouraging this. So the heart acts as a centralized pump, creates pressure and the resultant blood flow. Under high pressure, the blood flows through arteries of progressively smaller size, getting ultimately out to the capillaries. The capillary beds act as the exchange site where fluid will actually leak out of the blood vessels, and diffusion, the ultimate end goal of oxygen and nutrients going to our living active cells, and then carbon dioxide and waste products leaching back into that plasma. It's then resorbed back into the capillary beds and sent back through the low-pressure venous system. This goes on, which is why we call it the circulatory system. It's just a cycle. It's a circle. It repeats again and again and again. Capillary exchange, just kind of went through this. Interesting, a lot of people don't realize 20 liters approximately, average human, is how much fluid leaks out of these capillaries every day. And of that 20 liters, 15% does not go back into the capillaries. It resides there in the tissues. So there has to be some kind of balance in this. This is where the lymphatic system comes in. Lymphatics are something that we will often mention, somebody will discuss briefly, unless you have a specific history in a field that focuses on this. Osteopathy is a very common one. Lymphatics, in my experience in medical education and practice, are often brief. It's kind of overlooked and passed over. But the lymphatic system has its own capillaries that are going to leach that fluid from the interstitial space, pull it back in, filter it as part of the immune system, and then dump it back in at one of two sources to get back into the venous return and back into circulation. So 20 liters leaks out, 15% of that is dependent on the lymphatic system to return that. The system has to remain in balance. If you lose a balance to that, just like we think of renal disease, you can have a problem before you hit the kidneys or after you hit the kidneys. So in terms of lymphedema, we're talking about a lymphatic problem itself. When you get to the specific diagnoses associated with that, the lymphatic system has some kind of a blockage. For some reason, it's damaged. Rather, that's some kind of treatment, injury. A history of surgery is unfortunately a common cause. We damage a lot of microscopic vessels as we go in through the tissues. But as you damage that tissue, it is unable to siphon out the interstitial fluid, and it can't drain that. And so that 20 liters that leaks out, 15 that remains, it's unable to process that. And so instead of the 15% being a continuous cycle of slowly getting leached back into the venous return, that percentage increases gradually over time. On the flip side, we can have venous disease, where the lymphatics, they may be doing their job, but if the veins are overwhelmed, circulation is not returning, more fluid is going to accumulate. Either way, you end up with excess interstitial fluid and localized edema. So specifically looking at this cause for venous disease, because veins and the venous ulcers are the focus of this. Veins being the low pressure system in the lower extremities, they have to work extra hard. They're working against gravity. The blood from your heart all the way down to the tips of your toes is collimated. It has to work against gravity, and that pressure is going to build and cause problems. To combat this, the body miraculously has these valves built into it, and similar to the heart, they're going to make this blood flow directional. It's going to stop backflow, and it's going to help promote a venous return back to the heart for proper circulation. There is effects that can, limit this, multi-factors. Big one that often comes to our mind is valvular disease, that these valves, because of excess pressure, strain, some genetic factors, are going to weaken, seep and leak, or ultimately fail. Factors that do affect this commonly include age, greater than 55, being female, pregnancies, obesity, smoking, injury, venous thrombosis history, and sedentation, or a stationary lifestyle. When you get to the actual venous stasis, the low pressure system, overwhelmed as we were describing earlier, excess fluid in interstitial space, you end up with this edema. We often think of this pitting. It doesn't have to necessarily be. As you distend the tissues, you reach a certain point. And this is progressive. I describe to patients essentially a balloon. You can think of the tissue, and as you inflate it, it blows up and it remains intact, but that tissue will thin and thin and thin. And our bodies don't just pop like a balloon, but eventually, if left untreated, this distension will weaken them. You blow up a balloon the first time, it's difficult. You deflate it, you blow it up the second time, it's a little bit easier. As this fluid distension persists and it's not managed, the tissues will degrade. They will stretch, they will lose their elasticity, and ultimately they'll fail. And looking at the actual ulcers, which is that end result of failure of the skin to retain the interstitial fluid that is in excess because of the venous process, early on, you'll see a tightness of the skin. Literally, it looks like it's being stretched, and there's too much fluid underneath the tissue. You end up with these leaks. If you haven't seen them, they can be incredibly impressive early on. They can be just a very mild thing, but a little bit of moisture on this skin. Technical term is lymphuria. Generally, it's described as weeping. The skin literally is just weeping. It's leaking tissue. Just as I like to use common analogies, everybody's had a cold, everybody's had a postnasal drip, your throat gets sore, it gets irritated just from a simple little bit of running of mucus and fluid down the back of there. It's the same process with the legs. This tissue will stretch until there's a little crack. That little crack, the skin acts as a barrier, right? It keeps bad things out, keeps good things in. High pressure system underneath a little crack, it's gonna start to leak. Just like a dam that springs a leak, it's gonna be progressive. That leak will erode the tissues locally, and that's through two means physically. One is just kind of a leaky faucet as it pushes out. The other one that a lot of people struggle with is with the maceration that results locally. As a wound continues to weep and drain actively, the skin becomes macerated, the moisture persists, and the skin is very temperamental. Just as Dr. Freeman pointed out earlier, podiatrists, we very much believe if it's wet, dry it. If it's dry, wet it. In common medical practice, we like to say that wounds should be moist. I would like to emphasize that moist is a relative term. It's in the middle. It's not wet, it's not dry. It's a good, healthy moisture balance, and that's what we're aiming for with proper wound healing. But this moisture, if left unattended, and it's excessive, and in venous disease, it's going to be wet. It's gonna drain a lot. If that sits there on the local tissues underneath a simple bandage, you just have gauze, that skin will get soppy, it'll break down, and you'll go from a wound the size of a dime to a silver dollar very quickly. The presentation of the ulcers themselves, overwhelmingly, venous leg ulcers are going to be in what we refer to as the gator region. This extends from the mid-calf down to the ankles. It's circumferential. It can be anywhere within that range. Most common is going to be around the perimalleoli, so rather the lateral or the medial ankle, kind of correlated near those bony prominences. Physical presentation is often the darkened brown, purplish, a deeper hue of red coloration, this brawny edema. The toughness of the skin will increase significantly, those hemosiderin stains. Ulcers themselves, when present, they're irregular in shape. They don't appear punched out. They have kind of odd margins to them. They're generally shallow. The wound beds themselves are generally healthy and granular in appearance, although with all of that drainage, there's often slough and debris that's built up. Gentle cleaning usually removes that pretty well. Again, they're often wet, but you should pay attention to situations where they don't necessarily appear that way. One factor is they can crust over and hide the drainage. The other more common one that I've seen in my experience is patients may be seeing you earlier in the day and their legs aren't nearly as swollen. They don't have that interstitial distension. They're not actively draining. Give it time, ask the questions, ask them about what's going on, and then following up with wound care or whoever's changing the bandages most regularly. They are also slow to heal and highly recurrent. In terms of the underlying venous disease factors to represent and to notice, patients often describe itching in the areas. This can or cannot be associated with a rash. They have an aching pain, often describe night cramps in the lower legs. We have minor, small venous issues, telangiectasias, reticular veins. That's early on in the process, highly, highly encouraging proactive management. And then more chronically, you can get significant varicose veins, and then those skin changes that we talked about earlier, the brawning edema and the discolorations and the firmness to the tissue. In your assessment, it's important to be comprehensive. I don't know who all is present here, but it's clearly a multidisciplinary audience. Recognition is key. Communication. You might not be the one managing it. You might not ever provide direct interventions to it. Making sure that someone's aware, that the patient's educated, that we're engaged and we're involved, because this is something that in most cases can be very manageable with simple means, but patient awareness, education, and ultimately compliance are absolutely essential, and that requires all of us working together. We all know how stubborn patients are. With the edema, peripheral pulses are incredibly difficult to palpate. Doesn't matter how good you are, how good you think your sensation is, you can hold, you can push down. With time, maybe you can find it eventually. I think that's a waste of time often. If you have a Doppler, that's a nice, easy way to go. ABIs are fairly cheap and inexpensive. They're accessible. Vascular studies, being aware of potential arterial disease peripherally before you start very aggressively compressing can be very important. So just be mindful, up to 20% of these patients do have peripheral arterial disease as well. This is a classification system that I actually wasn't aware of before I did research for this. I don't know how much Dr. Lassar and his partners are using it, but in my world, the answer is the same. It's compression. Key principles of treatment. Like I said, I could give this in 2 seconds. The key is compression. Circumferential compression devices. It should extend from right around the ball of the foot, base of the toes, all the way up to just below the knee. General rule of thumb is 2 fingers. So if you bend the knee a little bit, there's a crease right there in the back, popliteal crease. Put your 2 fingers right there, and the compression sock should come up to just below that. If you go too high, you're going to cause irritation, potential wounds up within the popliteal folds in the back of the knee. I know, that's funny. And if you go too far out over the toes, you're going to squeeze the toes. You're going to get ulcerations, macerations, tinea pedis, you name it, all kinds of issues. Save yourself the hassle. There's lots of options. Compression socks are the general go-to. You have TEDs. You have multi-layer bandages, which we'll often use in more acute settings where we're trying to get a significant edema to a more manageable place. The ultimate goal is always get it controlled and then establish the long-term option, which would be compression socks. There are also pneumatic devices. That's far more commonly seen with lymphatic disease specifically, but they are available. Proper application and regular use, absolutely essential. If the patient isn't using it, it's not working. Compression, compression, compression. The main theme is we're squeezing the blood from superficial, incompetent vessels to the deeper venous system. Activity is essential. Getting up, getting about. This is a common thing with Una boots. People think you put an Una boot on and it works. It doesn't. Una boots require activity. The patient has to stand, they have to move. What it does is it causes constriction on the outside, and then when the calf muscles flex, it's squeezed inside because it's constricted, and it forces the venous return. This activity is essential. Other key highlights with the compression wear, avoiding wrinkles. Anterior ankle is a big highlight point of that. Some people have difficulty with the heel. They do make compression wear that has an open heel cut into it, so that's a factor. And then patient compliance is usually a difficult factor because they have trouble putting them on or taking them off. There are devices that help with this. There are also alternatives for the compression wear themselves. They have custom-made zip-up and Velcro options. The Velcro ones aren't even custom. You can buy those over the counter. And there's techniques as well. If you're interested in things like that, I'd be happy to show you how to put on socks. Wound care, we perform debridements, removal of slough and necrotic tissue, moisture balance as has been emphasized. Working with some kind of a wound care specialist, podiatrist, wound care nurse, you name it, is an important factor for that, making sure you have the right products. You can do this with gauze, but you're going to change the bandage 4, 5, 6 times a day, or you can use the right product and save yourself a lot of headache. Monitoring closely for infection, that's something any of us can be involved in. That can be a little bit confusing because these are often a little warm in the first place, so being familiar with the patient is helpful. And then all of these efforts without compression are worthless. Advanced wound care options that are available include negative pressure wound therapy, or VAC, trade name, growth factors and skin substitutes, that was touched on briefly earlier, thank you. And then surgical intervention, referral to our vascular colleagues is often an option. Usually it's after exhaustion of conservative means and patient failing conservative therapy. Long-term management, comprehensive approach. We should work together as a team. Patient education is essential. Optimization of comorbidities, diabetes management, blood pressure, things like that. Patient education, I think, is the biggest limiting factor in their compliance. If we can help them understand the importance that your wound will not heal with compression and it will not stay healed without compression, and just working together in that aspect. This is my daughter. I said she's going to be a wonderful doctor one day, and she said, "No, Daddy, I'm a queen doctor." So prepare yourselves for the future. If you have any questions, I'd be very happy for you to reach out to Angel Freeman.
last but not least, right? The brave few. Okay. I've been asked to talk about the biomechanics of wound care. I'm Aaron Solomon. I am a podiatrist at Village Podiatry Centers. Interestingly enough, my two colleagues here, we can do a Venn diagram, and a little bit of everything that we talk about is certainly going to kind of fall into the middle. There's a lot of crossover, which we could say that about every speaker that's been at this seminar, and I think there's a lot of crossover with everything we do. So biomechanics of wound care, I sort of, preparing this, I sort of went back to my pathomechanics notes from Dr. Schoenhaus's class, my second year of school, and, I could turn this into a treatise on root biomechanics, but, it's close to 5 o'clock and you're all exhausted and we don't have, 6 hours. So how do I sum up, biomechanics and sort of put it into a nutshell? Let's see, what do I do here? Green arrow? Yeah, okay. So, going back to a slide that, many of us have seen throughout the seminar and throughout our research and from many different authors, and, this was more recent, 2020, looking at the 5-year mortality and costs of, people, diabetic foot complications as compared to to certain cancers, and we could see where the mortality, the 5-year mortality of a diabetic foot ulcer is, and other conditions that we deal with, like Charcot arthropathy, which certainly falls underneath the realm of biomechanics. And we could see, compared to, it falls in between all cancers and breast cancer. So, and then obviously we get up to minor amputation, and then, it certainly gets higher, and we can see with critical limb ischemia, major amputation is obviously devastating and not that far away from lung cancer. So this, going back to save a limb, save a life, which is certainly a theme of the seminar. So speaking of Venn diagrams, so, risk factors for ulcerations, obviously peripheral neuropathy, diabetic or otherwise. Not every neuropathic patient I treat is a diabetic. And then obviously getting into biomechanics, deformity, Charcot arthropathy, equinus. I say it's the root of all evil because it plays such a role in a lot of deformities of the foot and ankle, but also a lot of deformities that result in ulcerations of the foot and ankle. So it's something that cannot be excluded, and many times, if this is addressed, solves a lot of problems. Obviously osseous prominences, metatarsal head, a hammer toe, a bunion, and then repetitive trauma, ground reaction force. Well, that's just walking, right? That's the ground pushing back on the foot. That's Newton's third law. Newton's third law. For every action, there's an equal and opposite reaction. The ground is striking the foot as hard as you're striking it. And then shear forces, that's sort of the side-to-side forces. That's your blistering forces. For us, it's a callus. Maybe it's a blister. We know it's there. We can feel it. Diabetic can't. They keep doing it. So we all know what diabetic neuropathy is, obviously. This is the definition by Dr. Bolton. Diabetic peripheral neuropathy defined as the presence of symptoms and or signs of peripheral nerve dysfunction in people with diabetes after the exclusion of other causes. We certainly talked about nerve compression and other things that can result in neuropathy. And once again, not every patient that comes to my office with a diabetic foot ulcer, with Charcot arthropathy, with a foot infection, is a diabetic. They're neuropathic, but they're not diabetic. And sometimes we know what's causing it. Maybe it's alcoholic neuropathy, maybe it's secondary to medication. Sometimes it's idiopathic, we're not quite sure. The classic neurologic exam, the quick neurologic exam. Obviously, we've had neurosurgeons speak here, and this is just the quick one you can do in the office. Sharp dull, monofilament testing vibratory with a tuning fork. Manual muscle testing that can sort of lead you in the direction possibly of nerve compression, certainly foot drop, other things that can really lead to neuropathy, like lumbar radiculopathy. Obviously, reflexes help in this manner. But your biomechanical exam. Assess joint range of motion. Take the ankle, the subtalar joint, mid-tarsal joint through its ranges of motion. The mid-tarsal joint is basically, it's a combination of the talonavicular and calcaneal cuboid joint. If you hold the rear foot and you move the foot side to side or up and down from that point, that's your mid-tarsal joint. The first ray is basically your first metatarsal complex with the great toe. It's important because it sort of has its own separate range of motion from the other rays, from from the fourth through fifth metatarsals. Because of that, it could be a source of ulceration. Obviously, its hypermobility leads to things like bunions and arthritis of the great toe joint. So we are also assessing the range of motion of the first metatarsal phalangeal joint, the bunion joint. Examine for osseous prominences. Just sort of look around. Is there a bony prominence somewhere? Is it a bunion? Is there a hammer toe? Is the base of the fifth metatarsal prominent? Is there a bone spur somewhere? Is it the bottom of the heel? Just a very, the malleoli of the ankles, which are a very common spot for ulceration. And then obviously, gait analysis. And, I'm not talking about sending them to the University of California Biomechanics laboratory and doing a pedobarograph. I have a patient walk down the hall. I'm looking for things. Is it apropulsive gait? Do they have shuffle gait? Is there an early heel off? Do they hyperpronate? Do they hypersupinate? Things that can sort of lead me in the direction as to what's going on. And this is a 5-minute walk down the hall and back. Going back in the classification systems, and Dr. LaPorte and Dr. Freeman both talked about sort of ulcer classifications. Wagner 0 ulcer, to some doctors, this is a callus, right? To me, this is a callus. Now we have two osseous prominences, one on the bottom on the arch, what we call the medial column, one on the bottom of the lateral part of the foot, the lateral column. But these are just osseous prominences. We can feel them, we can palpate them. We don't necessarily really have to know what joint it is. We just know that they're osseous prominences that have to be offloaded. But there's calluses, there's callosities to these lesions. These calluses, in the mind of somebody who treats foot wounds, a podiatrist, it is an ulcer. It is a Wagner 0 lesion. So according to Wagner, according to his classification, this is an ulcer. Pressure lesions. The sensate foot, you get a callus under the second metatarsal head, callus under the fifth metatarsal head. The insensate foot, that becomes an ulcer. They can't sense that pressure. They can't guard from it. It breaks down. As I explained to my patients, it's like wearing a hole in a sock. Basic foot pathomechanics, deformity and hypermobility, which plays a role in the sensate foot. If patients come in with a painful core and painful callus in the bottom of the foot, especially the second metatarsal head, that tells me that there's hypermobility of the first ray. The bunion bone, the first metatarsal, it's hypermobile, all the pressure's underneath the second metatarsal head. So somebody comes in there complaining of a callus underneath there, I know maybe an orthotic will help them, obviously, debridement of that callus, but in a diabetic, that becomes even more serious because that's going to be a site of ulceration. So once again, going back to osseous prominences, bunions, hammer toes, shear pressure, and what we call transfer lesions. Transfer lesions are really important. You take the third metatarsal head out because there's an ulceration under it, it's infected. Well, great, you got rid of that infected tissue, you got rid of that infected bone, you got rid of that source of ulceration, but now the pressure is going to be on the neighboring metatarsal heads. They could develop an ulcer. So we have to be wary of that. So once again, going back to the weight-bearing exam, we can see here that this patient has significant rear foot varus of the right foot. So do they have a varus or valgus heel? Do they have a planus or cavus foot? Do they have a flat arch? Do they have a high arch? Is it a rigid deformity? In other words, does it stay varus like this guy? Or when they stand, are the joints mobile? Sometimes a simple exam of whether or not there's adequate range of motion in joints. We do this a lot, especially with children who have flat feet. Stand up on your tippy toes. It activates what we call the windlass mechanism. It tightens all the ligaments and tendons. The arch will raise, the rear foot will turn in. It tells me it's a flexible foot now. Older patients who aren't so mobile, obviously it's a more difficult exam, but it is a quick test of mobility. So once again, going back to gait analysis, do they shuffle? Is it an antalgic gait? Is it painful for them? Do they have a stippage gait? In other words, are we looking at maybe a foot drop? Another term for stippage gait, we say quadriceps compensated gait because we're using the quadriceps to pull that leg over. Trendelenburg sign, is there more of a hemiplegia, a complete-sided weakness? So once again, this is what we're trying to avoid. Once again, that's a second metatarsal head lesion, but in this particular patient, obviously now we have a probing ulcer down to bone, and we can see obviously with the edema and erythema of the second toe that this is a surgical problem, and that's what we're trying to avoid. So Wagner classification, just as has been stated earlier, 0 pre-ulcerative lesion. According to Wagner, that's an ulcer. We treat that as an ulcer, especially in the neuropathic patient. I like to say, I'm saying the diabetic patient. I want to say the neuropathic patient because, sometimes a patient comes in, they have a neuropathic ulcer. I say, how long have you had diabetes? I don't have diabetes, doctor. So then, your grade 1, now we got your superficial ulceration into the subcutis. Grade 2, we're getting down to the capsule. Grade 3, now we have bone involvement. Grade 4, something's coming off. Grade 5, everything's coming off. And once again, I think Dr. LaPorte showed this with the University of Texas San Antonio classification system. And this is good, especially for a CLI meeting, because this incorporates not just infection, but it also incorporates infection and ischemia. And we could see that, all the way to the bottom right of this, the grade 3D ulcer is with infection and ischemia. So it combines both circulation and the depth of the ulcer. So simple ways to address the biomechanics of the foot. A wedge shoe. Take pressure off the forefoot. They do work. It's simplistic, but it does work. And, Dr. Freeman, she, I don't think there's anybody in my practice who does orthodigita better than her. She came to visit with me one day and saw some of my patients, and every one of them had some sort of pad either in their shoe or on their foot. It was really a great primer in orthodigita. Total contact casting, a little bit more involved of a modality, but it's a very powerful modality to treat a plantar ulcer. And there's a lot of different companies that make sort of total contact casting kits that make it a little bit more easier to do. You just be careful which company you choose. Some are good, some are bad. I don't have any conflicts. I'm not a spokesman for one or the other, but this system works well for us. And you can see that total contact casting is as it sounds. It's a very, intimate cast. It's directly casted as firm as you can without hurting the patient. That's why we have the felt padding along the anterior crest of the tibia and the malleoli. And actually, the next step would be to put some kind of egg crate foam over the toes. So, and it's a great way to distribute pressure off of a plantar ulcer. Prescription shoes, a rigid rocker bottom sole. Once again, we're distributing that pressure off the side of the ulcer, just like a total contact cast does. We use a multi-laminate insole. I like to use a tri-laminar insole. And the bottom of that insole, that's going to be a firm, hard layer. So the layer that's closest to the ground, it's going to be a little softer than the interface with the foot is going to be the softest interface. And that's the conforming top layer. So increasing rigidity as the layers go closer to the ground, and that's pressure dispersion. Cutouts, just like Dr. Freeman talked about, reducing focal pressure on the metatarsal heads. And shoes can be custom built around the foot. If some patient comes in, they have just a completely whacked out Charcot foot, previous amputation, whatever it may be, you're never going to get a pre-built shoe, pre-made shoe, diabetic or otherwise, to fit that foot. Well, an orthotist, pedorthist can build, they can take a mold of the foot and build the shoe around the foot. And then obviously an ankle foot orthotic can be combined with a shoe, because now we're addressing ankle range of motion and ankle support along with foot support. So insoles, a couple of different insoles. This is bottom side of sort of a diabetic orthotic. This is Corex. It's just sort of a cork material with a first metatarsal head cutout on the bottom. And then the other side of the orthotic has sort of a soft conforming layer. This on the darker insole on the left of the screen is it's a carbon fiber plate basically, and these are great. Most orthotists that are especially in town, Stubbs or ONP, PPS, all these different companies, Southeastern, they have these carbon fiber inserts. Basically, you slip it underneath the patient's existing insole, and what it does is it prevents excessive bending, particularly at the metatarsophalangeal joints. And that alone takes a significant amount of pressure off an ulcer. So you incorporate this carbon fiber insert with the diabetic insert underneath the diabetic insole, and that takes a significant amount of pressure off plantar ulcer. This is a polar bear in a snowstorm. 4-foot fillers for like a transmetatarsal amputation. You want to fill in the defect from what's been resected. And this is the diabetic insole. kind of hard to see on the front, but you can sort of see the cross section of the materials as they get closer to the ground. So some things that we can do to address biomechanics a little bit more invasively, surgically. This particular patient had a plantar first metatarsal head ulceration. It was found to be directly underneath the tibial sesamoid. So a procedure that we do sometimes for painful calluses, let alone ulcerations, is a tibial sesamoid planing. What that is, we can go in there and do a tibial sesamoidectomy. If the tibial sesamoid, which is the medial sesamoid bone, is infected, obviously we have to take it out. But if it's not infected, we could just make a little medial incision and we could skive off the bottom part of that sesamoid bone. We can identify it. I usually do it under fluoroscopy to make sure I'm in the right spot. It can be done with a saw. It can be done with a side cutting burr, and you just sort of shave down that sesamoid bone. And then that shear pressure is relieved. You can see the little medial incision that I made. I didn't really do anything with the ulceration. I just went in from the side, the medial side, took down the tibial sesamoid a little bit. And what that does is it preserves the tibial sesamoid. As you can see with this patient, they have a little bit of a hallux valgus. We have two little sesamoid bones underneath our big toe joint, and they act as little kneecaps. The kneecap is a sesamoid bone. They're the fulcrum when we push off and when we walk. You take that tibial sesamoid out, you're giving mechanical advantage to the fibular sesamoid. The lateral sesamoid is going to pull the big toe laterally, and it's going to accentuate that bunion deformity. Vice versa, you take the fibular sesamoid out, which foot surgeons used to do years ago as a treatment for a bunion deformity. Just the opposite, the big toe is going to go in and you're going to have a hallux varus, and we don't want that. So this way we're preserving the biomechanics of the first metatarsal phalangeal joint and at the same time addressing the increased pressure underneath that plantar ulcer, and we're able to reduce that plantar ulcer. Once again, talking about transfer ulcers, this patient was interesting. This gentleman, this infection started in his arch and went all the way up his leg. We had to open the anterior compartment of his leg. He had a necrotizing fasciitis. But all that healed, and it's beautiful, and what's the one thing that we're still dealing with? What's the one headache we have? Well, I had to take that third ray out, so now we have that second metatarsal head ulceration because we lost that third metatarsal head. So this is an example of a transfer lesion or transfer ulceration. So, plantar pressures due to loss of metatarsal heads. And this particular study by Garcia Madrid, this was done out of Spain, and they basically measured plantar pressures with the loss of a neighboring metatarsal head, and we could sort of see, for example, removal of the fourth metatarsal head. You can see the amount of pressure that's underneath that third metatarsal head, and then for the sake of the last slide, we saw that third metatarsal head was excised, and we can see that there's increased pressure underneath the second metatarsal head. Oddly enough, the pressure underneath the first metatarsal head is extreme according to the study. So some of it kind of matched up, some of it didn't. But obviously, the take-home is pressure increases with loss of a neighboring metatarsal head. And then obviously, you do a ray resection. So we go in and we take out the ray, and treat this post-surgical wound with a wound vac and local wound care. And but once again, according to that little diagram we saw, the greatest increase of pressure with removal of this ray is to the second metatarsal head, which it increases to about 27 newtons per centimeter, and that's sort of the average pressures. And really, the take home, I don't want to get too esoteric here. The take home is that the first ray hypermobility is what leads to the plantar pressure underneath the second metatarsal head. The first ray has its own independent range of motion. That's why sometimes the lesser metatarsal heads bear so much more pressure. So that's why we see when a ray is removed, why the pressure is so high underneath the second metatarsal head. And here's an example of a transfer ulcer from loss of the fifth ray. So you take out the fifth ray, the pressure goes to the plantar aspect of the fourth metatarsal head. Now, loss of fourth and fifth rays, this is interesting. I have a young man who had a necrotizing fasciitis, very young guy in his 30s, who we had to take the fourth and fifth metatarsals out because of the tissue necrosis. He went on to do really, really well. So you can remove a fourth and fifth ray, and patients typically can do well. Now, obviously, we have him in prescription shoes, and he's doing okay. But we have to be leery of that pressure, especially underneath that third metatarsal head. So if we're missing a metatarsal head, we have to make sure that we're keeping an eye on the neighboring metatarsal heads just for that transfer pressure. Oddly enough, if you remove a second and a fourth metatarsal head, the risk of transfer ulcers far higher than loss of the third and fourth metatarsal heads, or fourth and fifth metatarsal heads. So if you have to remove those outside rays, patients typically do a lot better than if you remove, let's say, the second and third or the first and the fourth, because there's just this sort of extreme pressure to those neighboring metatarsals in that system. Plus, it's easier to offload if all the rays are together. And transmetatarsal amputations, okay, now we're taking all the metatarsals off. So we think, okay, there's no more metatarsal heads. What's going to be the problem? Well, now we have a risk of stump ulceration. We're shortening that lever arm of the foot. We're also cutting every tendon to the foot except really a few tendons, like tibialis anterior, peroneus brevis, and of course the triceps surae, the Achilles tendon. So increased plantar pressure on the distal stump, risk of equinovarus, like we talked about, due to the pull of the tibialis anterior and Achilles tendons. So what do we do to combat this? Ankle-foot orthotic, rocker bottom shoe with a filler, and then we have to get surgical. So we think about a tendo-Achilles lengthening or a gastrocnemius recession. And if you want to get really fancy, you can do your split anterior tibial tendon transfers and tibialis anterior transfers. I tend not to like to do these if you have a patient who's a neuropathic diabetic, making tunnels through their subcutaneous tissue sometimes doesn't bode too well. So I try to save these unless we absolutely have to do them. Gastrocnemius recession is a great way to address equinus, and what we want to try to avoid, especially in a neuropathic patient, is over-lengthening the Achilles tendon. You over-lengthen the Achilles tendon, you get a heel ulcer. Heel ulcers can be very difficult to heal, pardon the pun, because when you over-lengthen the Achilles tendon, we have now what we call, instead of equinus, you have the opposite of equinus. You have calcaneus. You have what's called a calcaneal gait, and now all the pressure's underneath the tuberosity of the calcaneus, and we end up with a heel wound. So there's two ways to address equinus. You can either do what's called a gastrocnemius recession, or you can do an Achilles tendon lengthening. Gastrocnemius recession is a great procedure. You can bear your patient. The patient can bear weight in a cam walker. It reduces pressure on the distal foot stump. It reduces pressure on forefoot ulcers. It eliminates the deforming force in a Charcot foot. One of those very first slides. Equinus is the root of all evil. It's the deforming force in Charcot arthropathy. Sometimes all you have to do for a Charcot foot is lengthen the Achilles tendon or do a gastrocnemius recession, and that solves the problem. The ulcers heal, the foot coalesces, and you just have to put them in a surgical shoe. The benefit of the gastrocnemius recession, now we're limiting excessive lengthening of that Achilles tendon. So we want to avoid that calcaneal gait, which results in the heel ulcer. So gastrocnemius recession, small incision, posterior medial. You can see that the crural fascian, subcutaneous, and skin have been retracted. We've identified the gastrocnemius aponeurosis. We can see the distal end of the medial head of the gastrocnemius muscle. We're doing a horizontal transection of that gastrocnemius aponeurosis. Years ago, when I was a resident, we would start, if we were doing a flat foot reconstruction, we were doing a gastrocnemius recession, the patient would be prone. We'd make a posterior incision. We do what's called a tug and groove, where you sort of make two little incisions, followed by making this little sort of inferior projection and separating it, sewing it back together, and sewing in layers. And then you had to break scrub, supinate the patient, re-scrub them and everything, and do the remainder of the flat foot reconstruction. Here, patient can be supine. You just sort of you externally rotate the leg a little bit. The one thing you don't want to do, and I didn't put in here, is you don't want to frog leg the patient. And the reason why you don't frog leg the patient is because now you've taken the gastrocnemius out of the picture. If you bend the knee, then you take out the contraction of the gastrocnemius. because the gastrocnemius originates from the femur. So it's one of the ways that we sort of assess equinus. We assess an equinus basically is the foot doesn't go up enough, it's pointed down too much. So when we assess equinus, we're assessing it to see if it's caused by the gastrocnemius or if it's caused by the gastrocnemius and the soleus muscle. And the way we do that is if we can't get the foot to go, it's 10 degrees of dorsiflexion at the ankle, then and the leg is extended, we know there's equinus. Now, is it the gastrocnemius that's causing it or is it the soleus that's causing it? If you bend the knee and the foot now goes up 10 degrees, you know it's the gastrocnemius, that's the culprit. If it doesn't, then you know it's both tendons and you have to do a full Achilles tendon lengthening. So once again, gastrocnemius epineuritis is isolated, and underneath it is typically the medial head of the soleus muscle, horizontal transection. What you want to be careful of is when you get in there and you see this nice glistening aponeurosis that you're not staring at the soleus aponeurosis and you do what's called the soleus recession. It's not going to hurt anything, but it doesn't really help anything. And if you encounter the plantaris tendon, helps to transect this as well, and you close in layers. So you can see the soleus aponeurosis underneath the cut, gastrocnemius aponeurosis. Here's the plantaris tendon under my finger there. So first metatarsal head stump ulceration, you can see sort of the marking for where I'm planning to do the gastrocnemius recession. This is post-recession. So now this was, let me throw in, this was not just the recession. She also had a prominent stump to her first metatarsal that had some hypertrophic bone that was not helping. So we took that hypertrophic bone out. But once again, let's take into consideration that callus underneath the second metatarsal head. That's, if I shorten that first metatarsal even anymore, we're probably going to have an ulcer there. So obviously we have the decreased pressure. We don't have the transfer ulcer. We have the original ulcer healed, and I think a lot of that has to do with the fact that we negated the deforming force of the equinus. Your classic Charcot foot, you see the big plantar prominence there. We know just looking at that, that's going to be a source of an ulcer. You know, this is X-ray of the Charcot foot. We could see what we call a bayonet deformity, where the forefoot's basically sitting on the rear foot, on top of the rear foot. But it deals with all components of biomechanics, hypermobility, plantar prominence, preulcerative callus, ulcerations, ankle equinus. We can see that what we call the negative calcaneal inclination angle. Foot should be an arch. This is the opposite of an arch. This is an upside down arch. So instead of the calcaneus going up like a truss, it's going backwards. So we say it has a negative calcaneal inclination angle. So equinus here is the deforming force. So if, let's say you go in and do a Charcot foot reconstruction, but you don't address the calcaneus, your reconstruction will fail. Your plates will break. Your screws will back out. It basically won't work. So, you know, conservative options for a Charcot foot: your trilaminar insole, rigid rocker bottom shoe, ankle foot orthotic, a crow boot, which is a Charcot restrictive orthotic walker. It's a big clamshell boot that can be made by a pedorthist. These are good to help treat Charcot arthropathy, ulcer or no ulcer. They're also a great way to sort of allow your reconstruction to heal. Post-reconstruction, patients go in a crow boot for a while. Total contact casting is great for acute Charcot arthropathy. It addresses ulcers as well as the Charcot foot deformity. And then once again, isolated tendo-Achilles lengthening or gastrocnemius recession with or without plantar plating. So I call this pseudo-conservative. So instead of doing this big Charcot foot reconstruction, all you do is lengthen the Achilles or the gastrocnemius tendon, and that calms the Charcot down, that heals an ulcer, prevents an ulcer, and all you do is transfer them to a prescription shoe. Well, all you've done is one little surgery as opposed to doing, you know, a big Charcot foot reconstruction. And this is just a medial column fusion where we just reconstructed the arch in this patient. You know, these work well, and you only have to make one big incision. Sometimes, though, you still end up with some motion because that subtalar joint, that's the joint between the talus bone there, which is under the ankle, and the calcaneus, the heel bone, still allows for motion, and that can put stress on the plate. So you can incorporate a subtalar joint arthrodesis with that medial column fusion as well, and that helps sort of make a stable construct. But once again, this is done with an Achilles tendon lengthening or gastrocnemius recession, or eventually that plate that's over the over the medial column there, eventually that plate will fatigue and it will break. This is just a study that just showed that there was a significant decrease in the rate of complication in Charcot foot reconstructions if you fuse the subtalar joint. I don't want to turn this into that could be a discussion all of its own. So thanks for hanging in there and listening to my spiel. I appreciate it. And if anybody has any questions, happy to answer.